Good evening, everyone. Our today's topic is colorectal cancer, early diagnosis, update on screening guidelines. I hope this is informative lecture for you and it will be an interactive session as well. So I'll be happy to answer all questions that you have at the end of this small talk. Can I have next slide, please? And can everyone hear me? So the colorectal cancer incidence, as we can see in this slide, that it is the fourth commonest cancer diagnosed in United States. First commonest one being breast and lung cancer incidence is somewhat decreasing as the smoking awareness and cessation awareness is in progress for past 2+ decades. Colorectal cancer diagnosis in estimated new cases were about 147,950 in year 2020, and the mortality was still estimated death was 53,200, somewhat higher than prostate cancer and breast cancer. Here, probably it is early diagnosis of the breast cancer, and prostate cancer is because the biology of the tumor. In colorectal cancer, this can be improved with appropriate screening and early detection. Next slide, please. So the percent of cases in the 5-year relative survival by stage of the diagnosis of colorectal cancer, as we can see, the localized colon cancer, when it is confined to the primary site of origin, close to 40% of them are cured with surgery alone. When it is regional lymph node metastases, 35% of them are cured with surgery and requires adjuvant chemotherapy and sometimes radiation therapy, depending upon if it is in the rectum, where you would require radiation as well. When there is a distant metastasis, survival goes down, especially if it is multiple metastases, sometimes single site metastases and less than few metastases, it can be resected, and once again, 5-year survival can be improved. When the stage is unknown or unstaged, that is because there is so extensive disease, then the 5-year survival is dismal, unfortunately. Next one. So when we analyze this by race and ethnicity and the diagnosis of colorectal cancer, it is somewhat higher in African American population compared to Caucasian, and it's a bit higher in male than in females. And whether this is due to lifestyle, whether this is due to genetics, whether this is due to lack of proper surveillance, and therefore there is a disparity is unclear. Maybe it is combination of all three, that if you have proper screening colonoscopy is done, and if the polyps are removed, then one doesn't get the cancer, and therefore the incidence would be lower. So awareness is very important to diagnose the to prevent actually cancer. And then of course, if you diagnose early, then the survival is better. Next slide, please. While when we look at the median age of diagnosis and median age of average person who is dying from colorectal cancer, this number and the age is actually reducing from 67 to 75 further and further. And that is why the screening colonoscopy age is also now, instead of 50, has become 45, as we are noticing earlier and earlier diagnosis made. And so while the median age of mortality is 72, it probably would be somewhat lower if the diagnosis is made later in the stage of the disease. Next slide, please. So once again, when we look at the, go back to the previous slide, please. So once again, when we look at the death rate for 100,000 persons by race and ethnicity, We also once again see that there is mildly increased uh, number in Black females compared to Caucasian females and Black males compared to Caucasian males. And once again, the stage when it is diagnosed, as well as access to the healthcare may be playing role in this disparity of the numbers that we see. Next slide, please. So colon cancer is a cancer of the large intestine, which starts from the right side of the lower abdomen, where it is called cecum, where it meets the small intestine, and then it is ascending colon, then it is transverse colon that goes across the abdomen, and then the descending colon that comes down the left part of the abdomen and ends into rectum and into the anal canal. So in the order of progression is such that there is a benign small polyps. If left alone, these polyps ultimately become adenomatous polyps, and then they go and undergo certain chromosomal changes and genetic alteration, and then they become cancerous polyps. Therefore, it is very essential that if these polyps, when it is in early stage, benign polyps are removed, then chance of developing colon cancer decreases significantly. These procedures are done periodically depending upon what's been found on a colonoscopic evaluation. That is, if you have found a polyp, sometimes your gastroenterologist may repeat the colonoscopy in a year and sometimes in 3 years. If the colonoscopy is completely clean, then they may do it either in 5 years or 10 years, depending upon other risk factors that play a role. Next slide, please. So the signs and symptoms of colon cancer, change in bowel habits, that is, people who have prior history of constipation and now are having daily bowel movements or multiple bowel movements, or patients who are having normal bowel movements every day but now experiencing constipation, is a concerning sign. So it does not always have to be either diarrhea or constipation. Sometimes it can be alternating constipation and diarrhea. Also, it should be noted that if the caliber of the stool and consistency of the stool changes, that also is a concerning factor. It doesn't always have to be bleeding per rectum or dark stools. But when you have a bleeding per rectum, it should not be assumed that it is due to hemorrhoidal bleed, and not see your physician and not get proper evaluation done. It is when we sometimes identify that these cancers are growing while patients are under impression that this is probably hemorrhoidal bleed. Persistent abdominal discomfort, such as cramp, gaseous pain, with increased flatulence, are also symptoms that are sometimes associated with colon cancer, not always, but once again, to see the physician. So for proper history, physical exam, correlation with the personal habits as well as family history, and when the previous colonoscopic evaluation was done, all will play a role. So it is important to pay attention to these symptoms. By the time fatigue, etc., sets in or weight loss sets in, it is somewhat delayed in diagnosis. Sometimes fatigue is due to blood loss and anemia alone, but weight loss suggests that there is already some degree of spread. It should also be noted that many patients do not have any symptoms and they are incidentally found to have colon cancer. That is all the more reason to undergo screening evaluations. Next slide, please. So the risk factor, as one grows older, the risk increases. Up until now, the screening age was 50, but now it has been brought down to 45. In African Americans, as we discussed, that the incidence is little higher. Patients who have personal history of prior colonic cancer clearly have a higher risk of developing second colorectal cancer, and therefore we generally recommend a second colonoscopy within a year of diagnosis of first colorectal cancer. Patients who have multiple polyps or patients who have certain medical condition where we name it as adenomatous polyposis coli, meaning these patients have certain genetic mutations and they have multiple polyps. Those patients will require surveillance colonoscopies very frequently. Now, certain inflammatory conditions such as ulcerative colitis, Crohn's disease, are considered as real risk factors for developing colon cancers, and these patients are screened more frequently, preferably at least annually. Inherited syndromes, there are certain genetic syndromes, especially Lynch syndrome. So there's a family history of colon cancer or even upper gastrointestinal tract cancer or family history of cancer of the uterus and cancer of the breast falls into heredofamilial syndrome, and those patients should be once again monitored very closely. High fiber diet is a important thing to reduce risk for colon cancer. Patients who are having low fiber diet, high fat diet that is rich in processed meat and red meat have a higher incidence of colorectal cancer. Sedentary lifestyle, diabetes, obesity, smoking, and alcohol consumption are also linked to the colon cancer. They may not be cause and effect, but they increases the risk of developing colon cancer. Prior radiation therapy for other reasons can also increase the risk for developing colon cancer. Next slide, please. There was a small question placed by someone regarding Cologuard, and I would be going through all of the screening tests, including stool-local blood, FIT, Cologuard, CT colography, and colonoscopy. So that question will be answered. So for prevention, healthy lifestyle is very important. So eating varieties of fruits, vegetables, whole grains, not to smoke, not to have excess consumption of alcohol, moderate exercise, and maintaining healthy lifestyle and healthy weight are all important risk modification strategies for prevention of colon cancer, and screening for colon cancer is most important in prevention of colon cancer. I often tell my patients when they say, oh, I do not want screening colonoscopy, I tell them that you go for mammography, which is for a detection, whereas colonoscopies actually can be for true prevention, that if a polyp is removed, then you don't get the cancer. Still, sometimes patients have hard time accepting colonoscopy for several reasons. The preparation by itself is a little cumbersome, and some patients may not want to have sedations given to them for colonoscopy, etc. Some have personal preference, but hopefully by the end of this talk, everybody will have enough understanding to consider screening colonoscopy so that you can prevent the colon cancer. Next slide, please. So the precursor lesions that we were discussing is the adenoma, meaning already a polyp or a benign polyp has already become an adenomatous polyp. While it is still benign, not removed, these are the polyps that can become malignant. Serrated lesions are also considered as pre-malignant lesions. And when these lesions are removed, this patient should also be closely monitored for subsequent lesions. Next slide, please. So the goals of screening is go back to the slide, please. So the goals would be to reduce the incidence of developing the cancer by removing the polyp, early diagnosis so that you can reduce the mortality, and even with early diagnosis, you can reduce the need for chemotherapy and radiation therapy. So if you diagnose it early, in early stage, stage 1, and sometimes even in stage 2, you can avoid chemotherapy, and surgery alone would be intent to cure treatment. Therefore, early diagnosis is essential. Next slide, please. So this is more for your physician and nursing staff and uh, healthcare professionals to know. But sometimes when patients themselves are diagnosed to have colon cancer and they learn and read themselves on internet and Google, then it is good idea to understand that what's the difference between biological difference between right-sided colon cancer compared to the left-sided colon cancer. There are certain different types of mutations that right-sided colon cancers are associated with. And there are certain targeted therapies that we do for right-sided colon cancer uh, compared to left-sided colon cancer, such as KRAS mutation and mm, P53 mutations, HER2 amplifications are seen more often in hindgut, meaning the distal colonic cancer, compared to proximal colonic cancer, where you would be seeing BRAF mutations at a somewhat higher incidence. And you see in HNPCC, which is hereditary non-polyposis coli type of uh, disorders, which are genetic disorders, the right-sided colonic cancer is somewhat higher. Microsatellite instability, when it is high, we can give these patients immunotherapy and checkpoint inhibitors, and those are more often seen on right side of the colon cancer compared to left. Next slide, please. So when we look at what are the screening tools and how often we should be doing this in order to help reduce the risk of colorectal cancer mortality. So stool occult blood or stool guaiac, which oftentimes your physician would give you a prescription and you collect a card from the lab and smear the stool and return back to the lab. So US Preventative Task Force is recommending that to be done annually, and multiple other task forces, including American Society of Gastroenterology, recommends this to be performed on an annual basis. FIT, which is an immunohistochemical study done on the stool, is also recommended annually to be performed. Stool DNA test, where actually these precancerous lesions that are shedding the cells and are detected in the stool are one way to identify if one has precancerous lesion or cancerous lesion. And these things sometimes can help in patients who are unable to get colonoscopy or do not want to get colonoscopy. Is one way to identify, do they have any lesions that are potentially be identified and be screened for. Flexible sigmoidoscopy, uh, we do less and less because it is only giving us information on the distal part of the colon and not the entire colon. Yet patient still has to go through the preparation completely, just like the patient would go for preparation for full colonoscopy. And also the flexible sigmoidoscopy is going to give you information regarding partial colon while you also have to still go through some form of sedation. Uh, in patients who are otherwise healthy and who don't have other risk factors, including family history or any genetic syndromes, one can consider sigmoidoscopy or colonoscopy on an every 10-year interval, provided your baseline colonoscopy is normal. Uh, Patients who have other risk factors, this interval may change from 1 to 3 to 5 years. CT colonography is one way to look at by the evaluation with CAT scan rather than doing actual colonoscopy. And generally, this is also considered somewhat less sensitive. However, if that is what is to be considered, it is recommended to be done on an every 5-year basis. And then circulated methylated SEPTN DNA, this is something that's a blood test where it is preferred modality for any patient. These are actually circulating cancer cells that are being detected. This is yet not proven and we don't have proper sensitivity and specificity. Therefore, it is not included in guideline. and generally not performed. Next slide, please. So I briefly touch base upon the FIT, which is fecal immunochemical test, or the GUAC test that is done, which is the occult blood test done. These are non-invasive methods where patients are given the kit at home and the stool is smeared for 3 days in a row and is returned back to the lab for testing. And if the occult blood is identified, then the source could be anything. The source could be upper GI tracts, the stomach, the small intestine, or could be large intestine. So then it would require an evaluation by a gastroenterologist to once again look at the symptoms and then determine what test should be done first. Sometimes endoscopy, colonoscopy, and capsule endoscopies are performed to identify the source of blood in the stool. Stool DNA testing, as I mentioned, that this is Cologuard test. Someone had asked earlier that do you perform Cologuard test? That is a stool DNA testing. And once again, it is a non-invasive test that is to check the colorectal cancer, as certain genetic changes occur in the colonic lining, and you can precancerous or cancerous growth cells can be seen in the stool through this particular test and can help. Once again, this is not 100% diagnostic, whether it is precancerous or cancerous cell. So patients still would require colonoscopy if the Cologuard test is positive to understand, is it a polyp, is it malignancy, where is it, and how do we approach? So it is an FDA approved test, and generally it is performed on an every 3 years basis. Next slide, please. So the visual test is the test that is recommended. One of them is colonoscopy, another one is CT colonography, and flexible sigmoidoscopy. I kind of briefly touch base upon all of these. So I'll be happy to answer any questions that one has at the end of this talk. Next slide, please. So the comparison of the key features of the screening strategies, when we look at the strategy and the effect of cancer mortality, that when we do stool occult blood test, when we do Cologuard test, when we do sigmoidoscopy, when we do colonoscopy, what happens to the actual, how are we determining that one test is better than the other? Because we have to then look at what is the sensitivity and specificity of this test and how is it affecting the mortality rate in the community and population at large. So when we look at the stool occult blood test, the mortality is reduced by 32%. Flexible sigmoidoscopy, it is reduced by 27%. Once again, as I mentioned, that it only looks at the distal colons, it does not give you full information. When you look at FIT DNA test or the Cologuard test, the randomized control trials are not available to determine whether this is an effective way of reducing mortality. Colonoscopy reduces mortality rate by 68%. CT colonography is unclear, and circulating DNA for the cancer cell is actually already diagnosing a circulating cancer cells, and it is unknown as to how often it should be done. Is it cost effective? It is desirable test because it's a blood test. However, it does not really detect any precancerous lesions because these are cancer cells that are circulating. That means patient already has the cancer. And therefore, we don't have enough information regarding how effective it is to reduce mortality. Hopefully, someday we will learn more about this, but currently we don't have the proper guidelines to perform such tests. Next slide. So the advantages of colonoscopy, it is a highly sensitive test to detect and remove precancerous and cancerous lesions, or at least biopsy the cancerous lesions. And it's a one test that gives you the whole information rather than doing a stepwise approach, meaning you do a stool test and then you do a flexible sigmoidoscopy and then you do full colonoscopy. Long intervals between the examination, which is actually most desirable for the patients. To go for screening colonoscopy is unpleasant thing for patients to do because preparation is a problem, then taking a day off, then somebody has to drive them because they have to be sedated. It's all inconvenience, but if the inconvenience is for one time every 10 years, I would say it is worth it. And if patients who have high risk, it is one time every year is worth it because then you are detecting cancers early or you are preventing. And so then you don't have to go through major operations, chemotherapy, radiation therapy, all of that. So it incidence and the mortality is 80% in the left side of the colon and 40 to 60% in the right side of the colon. You can reduce the mortality. So it is significant advantage of performing screening colonoscopy. Next slide, please. Next slide. Yeah. So everything comes with its pros and cons. There is a disadvantage. Bowel cleansing preparation is just horrendous for all patients. People don't like it. Also, when you have a patient who has a kidney problems, who have certain electrolytes problems, well, then bowel cleansing can be a problematic where they can get dehydrated and get electrolyte imbalance. Perforation is fortunately not common, but if you practice long enough, you would see that yes, patients after colonoscopy present with perforation. So granted, while the incidence is very, very small, it is 0.5 per 1,000 screenings that you have done, still for that patient is 100%. So there is always a small risk and small concern on the part of patient when a screening colonoscopy is going to be performed, that perforation, if it occurred, then they would require some form of surgical intervention. And so that is a real disadvantage. Bleeding can occur. Generally, bleeding are self-limiting. Sometimes patients do have to come to the emergency room for bleeding, but most of the time bleeding can be cauterized by identifying the bleeder, and most of the time bleeding is not profuse when one would have to do any kind of surgical intervention. For 100,000 population screened, maybe that the mortality is about 2.9, meaning is this due to sedation? Is this due to electrolyte imbalance? Is this due to perforation? Is this due to bleeding? So if 100,000 people are screened, about 3 potentially can die from it. But when we look at the risk-benefit ratio, risk is very small. Risk is probably higher if one has to take an air flight and travel, or if one has to drive the car and go from one place to another place about accidental death, unfortunately. So risk comes with any procedure that one does. However, when you look at risk-benefit ratio, benefit significantly outweighs the risks. Aspiration pneumonia can occur, and that can be a problematic situation for people who have other underlying medical conditions, patients who are 65 plus and have an underlying COPD or heart failure. And if they develop aspiration pneumonia, then yes, they can wind up in hospital, in ICU, on respirator, or even potentially can have mortality related to it. Fortunately, incidence is once again small, but it is not zero. And so it needs to be discussed with the patient ahead of the time by performing, gastroenterologist. I'm not a gastroenterologist. I'm just discussing all of these. I'm an oncologist. So my goal is to educate my patients so that they don't get the cancer and they don't have to come and see me. And this can be prevented or can be detected early, and I can help reduce the mortality of this disease. Splenic injury is very, very, very uncommon. Fortunately, in 30 years of my practice, I haven't learned that patient had splenic injury and had splenectomy, although I may not be involved in these cases and may not know. However, this incidence is extremely, chance is extremely low. Certainly anything we do is operator dependent. So, your physician who are very good in performing these procedures, their incidence of complications would be small, but it would never be zero for any patient, any physician. Next slide, please. So with this, I would like to conclude the lecture. At Littman Cancer Center, we have support services. So one can reach out by calling this number, and our cancer liaison staff members as well as support service staff members can help answer questions and also help the services that are needed for supporting these cancer services in our area. Thank you.